Let's move on to relapse disease. I have to say, I'll start with my own experience. I found more and more that I don't wait. A patient's in a complete remission. I've been very happy for a couple of years, and then suddenly I start to see their light chain reappearing, low level, monoclonal protein re-level. In the old days, I would have watched that for months or even, sometimes a year before we started treating, gambling a little bit that we'd be there before anything bad happened. I find myself more and more just saying, let's just start retreatment because we can get you back into CR quickly. Is that other people's experience, or do you feel that you're still have a period of where watchful waiting is appropriate? And maybe Sagar, you start us this time.
Yeah, I mean, I think to me it really depends on how the patient presented initially. If they had high-risk disease, absolutely. If they had sort of explosive presentation with renal failure, yes. But for the most part, I'm still watching and waiting and trying to get a sense for tempo. And I may not wait for the hemoglobin to get less than 10 or the creatinine to go up to 1.8. But certainly if I see the hemoglobin drifting from 12 to 11.5, that may be when I intervene.
I think it may be helpful for also community oncologists to think about what we use for clinical trial eligibility as a guide as well, an M spike of 1 for IgG or 0.5 for IgA, a light chain of greater than 100. Because then at least if you change therapy, you know what you're doing. But if your M spike is 0.3 and you're adding a new agent and next month is 0.2 and then it goes back to 0.3, are you really gaining anything? So I think there needs to be some measurable disease or something to follow to change therapy.
Yeah, and so I agree. I mean, I think that you need to have one measurement going up. I think you have to have a couple of serial measurements saying that you're continuously going up. And I think in that case, when you have that type of relapse, then I think it's reasonable to start as opposed to waiting to have clinical progression. But I think that Blade previously showed that, there's about a third of patients who have this slow relapse and then they'll plateau out, and then they'll plateau out again for another 2 years before they need therapy. So I think you have to be careful about starting therapy right away in some of these patients, because there's about a 30% of patients that will have a slight rise, but then they'll kind of plateau out again for a long period of time.
I think that very much depends also, Jatin, on what they're on. I think a patient who's maintained, who's progressing, is a different person than someone who's unmaintained, and I think the data support that. And I think that a person who's maintained and is progressing biochemically, I completely agree, you can afford to sort of watch and wait.
In that patient, Paul, would you increase the lenalidomide dose, or would you switch therapy?
It's a great question. It very much depends. I've certainly, when a patient has said, look, why don't we just try and increase the lenalidomide and see what happens, I've certainly supported that. But to your point, I like your style here, Keith, in saying that, smolderers are sort of, innocent and proven guilty. Relapse is guilty until proven innocent. And I think, you have to think of it in those terms. So I agree with you. Yeah.
So you're more inclined to treat
more inclined to evaluate.
Than in the past.
Exactly, to evaluate, because it gets back to what we talked about much earlier, clonal heterogeneity and the clonal tiding, which is another phenomenology. Right. And I'm sometimes a couple of anecdotal experiences of really sort of how they frame your practice. When you're watching a patient and they come back a month later and they're in real trouble. Those kind of experiences crystallize why we need to be very careful.